All right, we'll go ahead and get started with today's sports ultrasound case series presentation. I have the pleasure of introducing Dr. Ali Beling. She attended Wellesley College and Tufts University School of Medicine, and then completed a residency in PM&R at Spaulding Rehabilitation Hospital in Boston, and is currently doing her sports medicine fellowship at the University of Utah. And today she's going to be giving us a presentation on snapping scapula syndrome.
All right, so good morning, everyone, and thank you so much for joining me to talk about ultrasound evaluation of the snapping scapula. In terms of what we're going to be covering today, I'm going to present a case, which was the foundation for this talk, and then go into a protocol for evaluating snapping scapula, and then wrap it up with the ultrasound report. So, in terms of our case, we have a 21-year-old male competitive boxer presenting for pain and crepitus located at the left inferior medial border of his scapula. And on exam, he has an audible popping noise when he does any sort of scapular protraction or retraction of the left scapula, and this is hindering his ability to participate in his boxing. Now moving on to a protocol to evaluate this with ultrasound. So the way that I have devised this is in relation to the bony landmarks of the scapula and using that as our basis so as to not get lost in the sea of muscles surrounding. When we look at the literature for reasons that folks can develop snapping scapula, kind of comes down to four main buckets. This includes muscle, bursa, bone, and soft tissue. And so with that in mind, when we're combining the bony landmarks with all of the other structures, this is the ultimate protocol where we are evaluating all of the structures together. And so we're going to go through each one of these one by one. I think it's important to note that this is sort of like a beginning framework for those who do not have much experience with scapular ultrasound, and that in this talk, I'm really focusing on the musculoskeletal side of things rather than the neuromuscular side of things, and focusing on mechanical symptoms as opposed to our classical conceptions of scapular dyskinesia. With that in mind, though, I highly recommend these presentations through AMSSM that were put on by Dr. Steele. They are excellent and well worth your time. In terms of technique for ultrasound for snapping scapula, I recommend linear probe to start, and then patient can either be sitting or prone. And so in terms of our first bony landmark, we're going to start at the top with the superior angle of the scapula. And so here we can see that this is where the levator scapula inserts. And so for our ultrasound, if we put one end of our probe on the superior angle of the scapula and then put the probe in the direction of the levator scapula, we can get a really good image of it and then recognize that below we're going to have our ribs as well as the pleura, and then we're going to have the upper trapezius overlying. And I think if we ever get lost when we're doing this, we can always go back to the fact that the trapezius is going to be overlying and is going to be our most superficial structure. The other thing to remember when we're looking at the muscles is recognizing that the spinal accessory nerve is going to be lying between the trap and the levator scapula. And so we can use that as a landmark to verify our position. I like this diagram just because it shows the nerves associated with the scapula. And then another way, as we're going along and scanning, we can go back to our glenohumeral joint anatomy. If we go a little bit more distal, we're going to start seeing the supraspinatus coming in here. And so we can use that as another way of finding where we are in space. So why do we care about the superior angle of the scapula? it has been described in the literature that this can be a place of uh, developing snapping scapula. It's referred to as Luschka tubercle. And folks can develop a bony prominence or a bone avulsion or a bone spur at the superior angle of the scapula. So you can see that on the left-sided image here. It's an axial CT scan. And then we have on the right side an MRI, a sagittal oblique. And this patient, same patient, has developed a scapulothoracic bursitis as a result of this bony prominence that's narrowing the space between the rib and the scapula. Okay. And so from here, we're going to change the orientation of our probe. Instead of being in line with the levator scapula, we're going to go in line the spine of the scapula. And so this is kind of like the grand central station. We have a lot of structures here. And so we're going to go through them one by one. Going with what we know to start, which is our bony landmark is going to be superior angle of the scapula. We know that the upper trapezius is going to be overlying. And then at the deep aspect, we're going to be looking for the serratus posterior superior structure here. And then we kind of, if you look at the picture on the left and compare it to the right, you can see, okay, rhomboid minor is going to be more medial. Then you're going to have levator scapula, more lateral. And then this little triangular shape here is actually going to be a little bit of the serratus anterior peeking out underneath the superior angle of the scapula. All right, so our first bony landmark is complete. Now we're going to move on to the scapular spine. All right, so in our minds, the spine of the scapula is extremely easy to find by palpation. And in a thinner patient, indeed, it might be easy for us to find it. Although in a larger patient, it might be actually a little bit harder than we anticipate. And so I'm going to show a video where I'm at the edge of the scapula and I'm scanning distally. And so what you can see here is on the left side of the screen is going to be the supraspinatus, the upper trap overlying. Here we have the spine of the scapula. And as I descend down, you start seeing the infraspinatus coming in here. And so as you're scanning, you just go, you're up, you see the supraspinatus, go down, you see the infraspinatus, and then you can find that level where you're exactly in line with the spine. And that's a helpful technique for us because that's how we're going to pinpoint the location of the rhomboid minor. So to review, bony landmark here, we have scapular spine. Then we have trapezius overlying, and below it is going to be our insertion of the rhomboid minor. We can evaluate that insertion for any abnormalities. The other thing that we can do is look for a neurovascular bundle. So below the rhomboid, the medial border of the scapula, we're going to see the dorsal scapular nerve running alongside the dorsal scapular artery. Of note, there's also a branch that goes to the levator scapula. And I would say this image is a little bit challenging because, to be clear, the dorsal scapular nerve is underneath the rhomboid, not on top. All right, we've done the scapular spine. Now we're descending down to the inferior medial border of the scapula. And so this is going to allow us to see the rhomboid major. And what I want to point out in this picture particularly is looking at the orientation of the muscle fibers. And so if you look at the image on the right, you can see that we are in line with the rhomboid major, and therefore we have the linear striations of the muscle proving that we are in long axis, as opposed to the upper trapezius, which is in a different orientation. So we're more on a short axis on the trapezius. And so as we're orienting the probe, we can use those striations of muscle to verify our position. Okay, and then I have a video here, which is showing dynamic scanning of the rhomboid major. And so in this video, the patient is being asked to retract and protract their scapula, and we're looking at how this rhomboid major is moving in a patient with snapping scapula to see if that is the source of their symptoms. All right, moving right along. Next one up is inferior angle. And so we have to recall that the inferior angle can be an origin for the latissimus dorsi. And so when we're scanning, if we have the patient inside lying, we have one end of the probe at the inferior angle of the scapula, and we're in line with a serratus muscle, show here. Then we're going to have this nice big muscle, which is the lat dorsi, which is going to be overlying, much like the way that more superiorly we have the trapezius muscle overlying. All right, and then why do we care about the inferior angle of the scapula? Similar to the superior angle, it's been described in the literature that this is a place where snapping scapula can develop and particularly cause a scapulothoracic bursitis, as seen on this MRI image on the right. Our patient has a large collection of fluid as a result of the bony prominence of their inferior angle. And for more information about the lat dorsi and teres major, I highly recommend this talk by Dr. Romero. So as a means of connecting our knowledge together. And moving right along, last but certainly not least are going to be our ribs and the surrounding structures. So as a reminder for our bony landmarks, very helpful to remember that T3 is going to be at the level of the spine of the scapula, and T7 is going to be at the inferior angle. And so in a patient with snapping scapula, does us well to evaluate the area where they're having symptoms and evaluating the rib on short and long axis, particularly because it's been noted that a malunited rib fracture can be a source of snapping scapula symptoms. In this image, I really like it because it's showing the potential bursal spaces for the scapula. And so the purple arrow is called the scapulotrapezial bursa. The blue designates the subscapularis bursa, and the green is the scapulothoracic bursa. It can be hard to visualize, but I do like this axial image where you can really see scapulothoracic is between the rib and the serratus anterior. The subscapularis bursa is between subscapularis and anterior, and the serratus anterior. And then here we have the scapulotrapezial bursa, which is more superficial. And then when we think about the deep muscles of the scapula, I want to point out there is this excellent article that describes putting the patient in a side-lying position and evaluating superiorly and inferiorly with a curvilinear probe, and that this actually allows us to get a good view of the subscapularis underneath the scapula, as well as the serratus anterior. So this image right here is the superior view. This is the inferior view. And then in this article, they point out that this is an example of pathology where there's a subscapularis atrophy. So I really liked this resource. All right. So now that we've gone through the protocol, let's go back to our patient. And what we did for him was a dynamic ultrasound at the place that he was having his crepitus symptoms. So this was the left inferior medial border, and I'm going to play the video now. So on the left side of the screen, you can see the inferior medial border of the scapula. And then on the right side of the screen, you can see that there is actually the sixth rib. As he's protracting and retracting his scapula, there's a bit of a pop as it comes back up, and that was recreating his snapping scapula symptoms. Here's another video that we have, again, showing this snap, crackle, pop of his scapula. So let's see here. Oh yeah, this is another video I just wanted to show you. Okay. And in terms of treatment, uh, we opted for a scapulothoracic injection at the place where he was having symptoms. And so for scapulothoracic injections, we're thinking of chicken wing position. And then this is a video. And so here you can see uh, the needle right in this orientation. And then if you look for it closely, there's a moment. So just to get our landmarks here, we have border of the scapula, serratus anterior. Deep here is a rib, and there's a little flash of pleura. Do you see it right there on the right bottom screen, where there was just a quick check of position to make sure that we are overlying the rib there for the injection. Okay, so in terms of our ultrasound report, evaluate the levator scapula, the rhomboid minor and major, the trapezius, dorsal scapular and spinal accessory nerve, and the ribs, all without abnormality. Our main finding being the visualized snapping of the left sixth rib with scapular retraction and protraction, which are recreating patients' typical symptoms. And so in terms of the patient's clinical course, the scapulothoracic injection gave him temporary relief of his pain, and then 3 months later, he underwent a surgical resection of the bone at the inferior angle of the scapula where he was having his symptoms. And he just followed up for his 3-month post-op visit last week. And at that time, he was reporting improved pain and relief of those crepitus symptoms. So I think my key takeaways are: 1, use bony landmarks. If you get lost, go back to what you know, and then use dynamic scanning, particularly for snapping scapula syndrome, so as to further evaluate it. These are my references. And I want to thank you all for your time and attention. I want to thank Dr. Cushman and everyone who has supported me in my journey. I'm happy to take any questions or comments.
All right. Thank you so much, Ali, for that presentation on this topic. Obviously, I think it's one that, as you kind of really went through in great detail, has very complex anatomy, also anatomy that we kind of don't always go over, and that sometimes can be a very unfamiliar, area for folks as well too, just because it's not going to be usually included in our standard, shoulder protocol. So that's the whole point of these presentations, is kind of go through what you demonstrated. It's coming up with a protocol, even if it's a area that we don't scan as frequently, coming up with a set protocol that you can make sure that you go through the standard structures that should be included in that area, just to kind of make sure that you don't miss anything. So I think this was a great presentation to kind of demonstrate a complete protocol, for this area. And as you had mentioned, some of the pathology, in this area can be varied as far as soft tissue structures, bony structures. Say most frequently, in this area, you can see the bursal distension, but the question, really, where is that kind of coming from? But definitely, as you alluded to, there are kind of different bursa in this area. And then usually in those scenarios, I think from a diagnostic perspective, for a lot of these patients, of course, before they're going on to any further treatments, those injections, can be very, very helpful. But for this area, since it is kind of a dynamic condition, you definitely have to kind of, get specialized with it, especially for these patients that they can kind of figure out how they can make that snapping occur, just because all that sometimes can be different motions. So at least kind of being flexible of, talking with the patient, what recreates your motions and things like that. Sometimes it can be protraction, retraction. Obviously, sometimes it can be, with abduction, adduction, as well too, for the scapula in that region. So I think just being flexible and obviously working with the patients on the dynamic motion that recreates, their symptoms, and then obviously just trying to localize it to that area of the scapula because usually they're able to do that fairly well. And then lastly, as you had mentioned in the presentation, I would always go ahead and get some, additional imaging with this, usually with, radiograph at least, just because some of these can be, bony problems. And so then working, using that in conjunction with your ultrasound can be really helpful. But overall, I thought this was just a very comprehensive presentation. And I think that was extremely helpful from a protocol standpoint. So thank you so much.
Thank you so much, Dr. Shah.
Yeah, this is Doug Hoffman. Ali, that was really, really well done. I have to be honest, and I don't really have thought through a protocol for the scapulothoracic region. And I really like the way you methodically essentially went from, cephalad to caudal. I really like it. Just a couple comments or actually questions for you or anybody, but um, one is that I've actually injected the dorsal scapular nerve several times in people who have this kind of chronic pain, and it's really hard to see a true compression of it with mixed results. I've had actually pretty good results in some people and no results in others. So my first question would be, what are others people's experience with that? Another comment would be, when you're scanning this area, you should be aware of a benign tumor in this area, and that tumor is a elastofibroma dorsi. And the reason why I mention it is because I've seen 3 or 4 cases of it where we're scanning the area. And a lot of times people say, well, yeah, I have a bump there. And it usually isn't a bump. But occasionally I have found a bump. And that's the most common tumor at the inferior angle of the scapula is the elastofibroma dorsi. So something to be aware of when you're scanning this area. Um, and I guess my other question would be to put out there is, I agree, Stephen, that I would rarely, complete the workup of a snapping scapula without probably another imaging test. And do people prefer an MR for this? Because you can see fluid much better, but you're going to lose a little detail of the bone, or do you prefer a CT scan? So I would just throw that out there.
Yeah, I think to kind of go through some of those questions, Doug. Yeah, I haven't honestly done too many nerve injections around the scapula. Honestly, the majority of times have just been referrals from the surgeons to do it for the bursa. So I can't comment too much as far as efficacy or effectiveness, for those injections. From my experience, at least for additional imaging, most of the time they've ended up getting like a CT scan, for the bony anatomy, in regards to that. It looks like Dan might have comments.
Yeah, thanks. This is Dan Cushman out in Utah, and I'd say for the dorsal scapular nerve, we've had the similar similar findings where it seems like it's quite hit or miss, but it's something to consider. It's definitely something to consider, and I agree. I can't quite envision how it gets entrapped, so to speak, but it can at least offer some relief. It seems like for some patients. And for the kind of imaging modality, at least how we've been doing it typically is actually starting with the ultrasound first, to kind of get a better idea of if this seems more bony or if this seems more soft tissuey. And in those places, if it seems more bony, we go straight to a CT scan. If not, we get the MRI at that point. And then finally for the elastofibroma, just a couple of quick comments on that is that here, those can be tricky. They're usually people who are a little older, generally female, and at least for those can be tricky to image because a lot of times it needs an MRI of the chest with without contrast, and they don't show up so discreetly. So it's something to definitely keep on the differential, but it can be tricky even with an MRI to figure out on some of these patients. So they're benign tumors, but they can keep growing, and they're tough to treat surgically, is my understanding as well. But it's a really good point to consider.
All right. Well, thank you for that further insight, Dana. I appreciate it. All right. Well, unless there's any other questions or comments, once again, thank you for the great presentation, Ali, and coming up with a set protocol, for this area. I think this will be very valuable for people to kind of go back to as a resource. Otherwise, we'll see everyone hopefully at the AMSSM meeting in a couple weeks. We will be taking a break from the case series presentation during that time. So the next presentation will be 2 weeks after the AMSSM meeting.
Excellent. Well, thank you, everyone. I appreciate the opportunity.